It's time now for the award-winning #1 local talk show in Northeast Pennsylvania, The Sam Lesante Show. Now here's your host, Sam Lesante.
Welcome to the Sam Lesante Show, folks. Today I have one of the leading orthopedic surgeons on the show. And of course you know who that is, Dr. Thomas Meade. For 18 years we've been doing shows and giving you as much information as we can. Today will be no exception. A lot of great things happening in orthopedic surgery. And Thomas, how are you?
Sam, I'm great. Hey, thank you for having me back. I missed you.
Yes.
It's great being back.
But you're on every day. You're on every day on our channels, okay, the Dr. Meade Show, which is, incidentally, I got to tell you right now, if your ratings get any higher than mine, you're off the air, just so you know that.
Well,
okay?
that's what a great job you do in producing the show, and I thank you for that, Sam.
So tell me, there's recently, to put things in perspective here, we talk about orthopedic surgeons, and you've been blessed to be one of the best in the country. But recently you went to Turkey, and it was the world's expert on orthopedic surgeries. Let's talk about that meeting and why it meant so much.
So it meant a lot for a lot of reasons. I've been fortunate to be in medicine. I can't believe, but this is actually, if I count medical school training after college, Sam, this is my 41st year in medicine, and really my 36th year as an orthopedic surgeon. I can't believe it, but yeah, I've been doing it for that long. But I've met a lot of great people over the years, and one of the professors that I met, who's a great friend of mine, has become a professor over in Istanbul. He was head of research in Philadelphia for a while, and he has a fascinating life story. But anyway, he is over there, and he organized a world expert meeting on hip and joint replacement surgery. And so he invited 300, and I was very honored to be even considered a world expert in knee replacement. But I was over there with world experts, not only from the United States, but from almost every country in Europe, Asia, China, Japan. And for 2 solid days, we explored some of the top controversies in hip and knee replacement surgery. And it will be published in a book coming out in a month or so, and it will be published in our largest peer-reviewed journals, all the conclusions that we had. But it was fascinating. I could spend the whole show on it, but basically we picked up every controversial topic, and our charge was to review the world literature on that topic. After we reviewed it, and we've been doing this for months, one of the folks on our team, for each of the 64 different topics, would do a 5-minute presentation of the world literature. Then we would present it to the world experts in the audience. We would discuss it for 8 minutes, and then we had 2 minutes to vote on it. And we would vote on either we agreed or disagreed on the conclusions in the world literature. And we'll publish those results. And if we approve them, it will become basically a standard of care or a guideline across the world for those different criteria in hip and knee replacement surgery.
All right, so let's talk about some of the topics that you talked about and what you discovered.
So, for instance, my charge was, as you know, I've been sort of one of the early adopters of something called kinematic knee replacement. So that's when we put in the knee in a more anatomical position instead of putting every knee in straight alignment. Like if you're bow-legged or knock-kneed, for years everybody would put them in the same. But basically what we do is put the knee in a natural alignment. If you're bow-legged, you end up in a natural bow-legged alignment. So we had to review the world literature and say, is putting the knee in kinematically get better results than putting them in the traditional way of mechanical alignment? I'll give you a quick example. Our topic was one of the most controversial. But even though it was one of the most controversial, when we reviewed the world literature and we presented it to the audience, 55% agreed with the world literature. So that's not 90%, but it shows you it's controversial. So the majority agreed with the literature that basically showed they were fairly equal. But in the early results, the kinematic alignment won. Patients preferred them in the earlier outcome measurements. They said it felt more natural. They had an earlier recovery, and it just felt a little better than the mechanical ones. But the world literature, when we followed it for 15 years, they sort of look the same. But you have to understand that kinematic alignment has only been around for 18 years. So it's going to take a while before we get 20 and 30-year results. So basically, the take-home message was, if you're a patient and you're looking at mechanical or kinematic alignment, and perhaps you want a knee that feels more normal, and you have a little easier recovery, and you get better results in the short term, maybe that's an option that you can discuss with your surgeon. So that's valuable information. And then there were 63 other topics that we reviewed, in hip and knee surgery.
What was the conclusion then that you came out with the kinematic?
Well, that, again, it was just that in the long run, at 15 years, there may not be a big difference, but it looks like in the short run, it feels like a more natural knee. So a lot of patients have a knee replaced. They go, I love it, I have no pain, but it doesn't feel like my own knee. When you get a kinematic knee replacement, patients will say, yeah.
Is it a different kind of
It's the same prosthesis, it's just how we put it in.
What were some of the other because when you have all these experts together, it must have been amazing, because these are people like you. I mean, God, how many surgeries, knee surgeries have you done throughout the years? Thousands.
22,000. Thanks for asking.
Okay, 22,000.
Yeah.
So I think you know a little bit about
Yeah.
it. So what were some of the other key things that we should know about?
Well, so let's say not everybody that does a knee replacement replaces the kneecap. Some replace the kneecap and some don't replace the kneecap. In America, 90% of patients have their kneecap replaced. If you have a knee replacement in Europe, only 50% do. So we looked at the world literature, and sometimes literature isn't all that clear because the publications have different biases and they have different statistical analysis. But is it better to replace the kneecap or not? And it looks like it's a toss-up. So, there's no great advantage. So when people come in and they say, I want my kneecap replaced or I don't, you could say, well, there's no real difference in the literature, but my experience shows that if I replace them, you have less problems down the line. So at least we could correlate the literature with our experience. And that's another topic for the second half of the show in Truth in Medicine. A lot of times the literature, it's not the Bible. It's not the absolute last word. I think you have to always correlate the literature with your experience. And as you go on, sometimes your experience is as good or better than the literature.
So here's a stupid question.
Go.
Okay. How do I know if I should be looking into getting my knee replaced? What are some of the symptoms? It's a stupid question.
There's no stupid question. You know what? People, and I answer this question all day long. My first answer is nobody needs a knee replacement. They look at me with this quizzical look, and I go, 50 years ago, there were no knee replacements. The human race did great without a knee replacement. For however long humans have been around, 100, 200,000 years. But you know what? Up until 100 years ago, the average lifespan was 45 years. Now we live twice as long, and we are more demanding, and we have better technology. So most people, will have a pretty miserable knee. It hurts them to walk several blocks. The anti-inflammatories aren't working. They've exhausted the non-operative options of injections and physical therapy. But big article in the Wall Street Journal in the last couple of weeks showed that one of the biggest growth areas for knee replacement is 40 to 60-year-olds. It's not the 80 or 90-year-olds that we used to. And they have different demands. They realize you don't live forever, and I don't want to live with a sore knee. I want to kayak, I want to ski, I want to play pickleball. So there's a lot of reasons that people are getting their knee replacements. It's basically a quality of life issue if they can't do those things.
How do you qualify for an outpatient surgery, and how do you not qualify?
It's a good question, Sam. So right now, I'll tell you, 95% of all my patients are outpatient eligible. You have to optimize their medical condition. If I told you that last week I did a 93-year-old patient, and she went home the same day, 2 hours after the surgery. The next patient had a liver transplant. And if you think these people are ill, It's amazing what we do now. You could do a liver transplant. If you looked at this patient, he would look like you or I.
You did the liver transplant?
No.
Oh.
He had a liver transplant, and I did a knee replacement on him.
Yeah.
And one would think, oh, that's a sick patient, and we have to. Yeah. I did scrub on liver transplants, believe it or not, when I was a medical student, as an aside, in Pittsburgh, the leading facility of liver
I'm shocked. I mean, me, are you kidding me?
Starzl, the leading liver transplant surgeon. See how I get tangential in the country? I scrubbed with him in Pittsburgh. Anyway, so we did these as now. My point is, the ability to go home is not almost as much a medical situation as it is a social situation. Meaning if you live alone, there's no one there to help you for a few days. But basically 95% of all people qualify as an outpatient.
The old adage is that the sooner you get something done, the better it is. Don't let it fester and fester, because it's just easier, I think, if you know that you have that concern up front. Is that correct in saying?
Well, it's true, but you don't want it at 20 if you don't need it. You know, you have to have pathology in the knee. It has to be worn out. And I always tell patients that want to put it off and put it off that living with a end-stage bone-on-bone knee has risks. And you know why it has risks, Sam? Because you don't do anything. You sit around, you can't exercise. And if you can't exercise, your weight goes up. If your weight goes up, your risk of a heart attack goes up, your cholesterol goes up, your risk of diabetes goes up. So there's risk of being sedentary and not having something done. So that is an indication to get it done sooner rather than later.
We talk about the advanced technology today, okay? Now, when you're talking about advanced technology, when you had this meeting of all the world experts, from that meeting, okay, can technology come from that meeting with all the input that you have from different orthopedic surgeons, and they look at, how do we address that and go one step further in technology? You know what I'm trying to get at?
So that, that's, how come you're so smart?
I don't know.
How can you be so smart? Ask the right question. You amaze me. But that was the conclusion of the meeting. We had 300 world experts there, and at the conclusion of the meeting, it said, this is the group going forward that we identified at that meeting, 64 different issues that needed addressment, but a lot of them are not solved. A lot of them, the literature does not have the answer. They say, we need more research, and this is the group, to your point, that has the skill set and the assets to ask the right questions, do the right research, and answer these questions. So at the conclusion of that meeting, that was the charge, that we will go forward and set up research protocols to do some of these things. But we also assessed modern technology like robotics and artificial intelligence. And at this point, that was one of the controversies. So one of the things that we looked at was, do robotics, people come in and they say, I want robotic surgery. Do people that have robotic surgery do better than people that don't? You know what the answer is? They don't. It's equal. So having robotic surgery, everybody thinks it's better, so it doesn't give you a better outcome. So people shouldn't worry if they have surgery that doesn't use robotic technology. But what we did find is robotic allows the surgeon to put the prosthesis in more accurately. So it's sort of an interesting controversy. Well then, how if it allows you to put it in more accurately, does it not give you better outcomes? Well, because there's other variables that give you outcomes. Everybody's different. Patient genetics, their weight, their size, their activity, their comorbidities. So there's a lot of things we don't know yet, but there's never one variable. So you have to be careful when, patients say, oh, my neighbor had a robot and they said it's better, faster recovery, better outcomes. We just showed over in Turkey that that's not necessarily the case.
So you've done over 22,000 surgeries, okay? And I remember many years ago when we were doing a show with Jack Palance, Jack said, every time you do a show, Sammy, look at it and think, how could you make that show, another show, 10% better than what you've done? Always fine-tune, fine-tune. So as a surgeon, when you were first starting doing replacement needs to where you are now, have you constantly been learning different things as you're doing these surgeries, Tom?
Sam, I've been doing it I've been doing orthopedic surgery for 36 years. It's amazing how much I don't know. I look at, and really all I've been doing is knee surgery for the past 20 years. I don't do anything else. And it's amazing, like this meeting, how much we don't know. And it's fascinating. Even this week, I've been using augmented intelligence on a new GPS computer navigation system in the operating room. And it's fascinating some of the immediate feedback we have with technology. We're using computers in the operating room where usually we used to have jigs that, let's say, for instance, I want to cut a 1/4 inch off the end of a bone, and now we just have this 3D dimensional piece of equipment that we put on that communicates by Bluetooth to the computer in the room and tells me what the alignment of the limb is. When I'm done, I go, yeah, it looks pretty straight. It looks like I have a straight leg. And then I just look at the computer and it says, no, Dr. Meade, it's 1.5 degrees off what you thought. So the technology that still allows us to learn is fascinating.
Amazing. Folks, I'm talking to Thomas Meade, Dr. Tom Meade. You see him every day on ssptv.com, on our website, on YouTube, and of course, channel 13, 513, channel 190 in Pottsville, and channel 92 in the Hazleton area, in the Wilkes-Barre area. And he's also on Comcast 190 now in the Scranton area. We come back, we have something, or he has something to talk about. We'll probably start a series on it. It's called Truth in Medicine. Now, this is going to be very interesting. Stay with us. Welcome back to the Sam Lesante Show, folks. And remember, thank you for making the Sam Lesante Show the #1 talk show in northeastern Pennsylvania. And that comes from the scientific poll from Susquehanna Polling and Research. I appreciate that very much. And all our shows are on our website, ssptv.com, and a YouTube channel. My guest today, no stranger to orthopedic surgery, Dr. Thomas Meade, who you could see every day here on SSP TV. Just recently came back from a world experts were in Turkey, talked about a lot of innovative things happening in orthopedic surgery. But now we are going into something that I found interesting. Tom called me and said, Sam, I want to talk to you about something, and it's that truth in medicine. And my God, we could spend hours on that. But just give us a synopsis of what you will be starting a TV series on this truth in medicine, and what made you decide to go ahead and do this.
So Sam, as we talked in the beginning of the show, really I've been in medicine for over 40 years, but I've been in clinical practice for 36 years. And even though I just do orthopedics, I've always been interested in the total patient when they come in. And I think I'm at a point in my career where I calculated I've had over 150,000 face-to-face meetings with patients, and we talked about over 20,000 knee procedures. But I guess one of the things that's my pet peeve that drives me crazy is misinformation in medicine. And I hear it every day, and it's just not in one space. So I spent a lot of my time disavowing misinformation in the office, and it comes from patients, it comes from their neighbors, it comes from their family members, it comes from their physicians, and it comes from the pharmaceutical companies, it comes from television. And I figured before I end my career, which is not close to being ended yet, I just want to reflect on the opportunity that I've had to be in one career really for well over 40 years and correct a lot of this misinformation. So I want to have a show, and I'm going to take it one topic at a time that looks at some of this thing and some of this misinformation. One of the things that drives me crazy is the direct-to-consumer advertising. And I think maybe what put me over the top is the recent barrage of commercials that we see on weight loss medications. All of the patients that are diabetic or obese, and they're on the Jardiances of the world and the Ozempics, the GLP-2 agonist, and it's like this miracle drug. And people are just dancing with these wonderful jingles on TV, and that's all they have to do is take this medicine, they stick it in their leg once a week, and they do wonderful. The sun comes out, the rainbow is up, life is great, and it's just missing the whole point of the root cause of this. It doesn't talk about the root cause, and they don't really care. For, to all due respect to pharmaceutical companies, what's their goal? Their goal is to make money for the shareholders. And anything they can do, would it surprise you that they spend 10 times the amount of money on marketing and advertising as they do in research? So once their R&D, it's as critical to come out with a new drug like Ozempic, they will spend 10 times the amount of money, Sam, that they spent to make it, to advertise it. And sort of, you only get, and it may be a wonderful life changer. They get celebrities on TV to talk about how it works, but that was the first trigger that started this. So in one of our shows, we're gonna address all these drugs, and I think they're wonderful for some people, but they have to know the downside. And I drill down on the downside of these things. I look at the papers and the research like we did in Turkey, and they don't tell you that 1 out of 6 patients have to stop it because of side effects. Side effects like gastroparesis, pancreatitis, nausea, and vomiting. And so it's okay, but I call it truth in medicine. I always say that one of the things I want in an office is a little box called the Truth in Medicine box, so that, I always correlate this to real estate. When you buy a house and you go to the bank and they're going to charge you 5% interest for your mortgage, and then you go into the little meeting afterwards, it's called Truth in Lending, and when you leave, you're paying 5.7%. And they say, well, why is that? Well, there's this fee and that fee and escrow. Well, I think the same thing happens in medicine. Docs are very, very busy. They're forced to run on that treadmill, and they have 5 minutes for an office visit, and you come in and you're 100 pounds overweight, and they say, I have a new miracle drug. And you go, sign me up. I have to lose weight. I can't lose weight. Then you go out, you should sit in a little box that's called Truth in Medicine. And they say, well, here it is, what the doctor didn't tell you. But we have to tell you, if we really look at the literature, it's not for everybody. There's no guarantee that you can lose weight. The literature says you might lose 5 to 10%. Did he tell you that you might have nausea, you might have vomiting? And did they tell you the way it works? It stops you from your stomach from emptying. And and there's a bunch of side effects that you can have. And once you know that, you say, well, geez, I didn't know all that, and there's some serious things, and they don't know this for sure, but there's been some question, does it cause negative thoughts, even suicidal thoughts? And we don't know the answer to this thing, but these things patients should know about if they were depressed in the first place. Anyway, so that's one of the things that triggered it, among other things.
Okay, so and we were having this conversation. The first thing I said to you is this. I said, first of all, it's important that you have facts, that what you're saying are actually factual. Number 2 is, once you've told me all this stuff, okay, what are some of the solutions that I have? So if I'm overweight, or if I'm in situation, and yes, I'm in the business of the television, I make commercials, etc. But the point is, sometimes I could create a commercial and, like you said, wonderful things, and sometimes that happens, but there's a lot of downside. So in keeping on the topic of, you have your facts of what you're saying, and you have hopefully some solutions in this show that you're going to present. Am I correct in saying that? Oh,
for sure. I think it's all about education. I think an educated patient, you don't want to be conned by something. It's not only weight loss, it's everything. In orthopedics, there's all day long we have to talk about the truth, and people come in and they say, I'm playing pickleball 2 days a week, but I want to play 5 days a week. I want a knee replacement. You go, whoa. This is not why we do that. This is not the answer. So we have to be very honest and give you the solutions. And for some people it's a great solution, but we don't know the long term. And in medicine, we've been terrible about doing things in the short run, and we find out a year, 2, 5, or 10 later it wasn't a good idea because there's negative side effects. So we're going to go over that and allow people to make an educated choice and make sure that's what they want. But not only in orthopedics, but in many aspects of medicine. And I'm a knee doctor. I may not be an expert, but I know how to read literature, and I know how to read the facts. And a lot of patients and even physicians are not trained in drilling down on some of the statistical manipulation that these companies use.
If you go to our website, it lists shows. If you hit shows, hit Dr. Meade shows. There are so many shows. In fact, it's one of the most popular hits on our website is the Dr. Meade show, and it gives you a lot of great information, particularly some of the seminars. You're conducting future seminars. Anything in closing you'd like to say, Tom?
No, but I'm on a library tour now. I like to talk, I like to educate. One of the things that I found out is the community libraries are a great place to engage in patients. I'm giving a talk up in Scranton and Quakertown, Pittston. So I'm on a library tour to talk about a lot of this also.
Okay, so just so you know, the show is played many, many times, so just look for it. Nice to see you again, and it's nice to know that your daughter had a brand new, beautiful baby. Mila, and I wish you the best,
Marie.
okay?
Thank you so much.
And your son's doing okay, my friend?
He's doing great.
Good. Remember, it's sam@ssptv.com for my email. And remember, go to our website and watch all of our shows. Thanks for joining us. We'll see you next time.